The session is on exploring gender dimension of health and CRVS. If you remember the takeaway from the breakout sessions, somebody, I wrote it on my paper, said that there is no gender data without women, girls' visibility, and without CRVS, right? Okay, somebody from that group, so you recognize yourself. So this panel is going to be speaking to that, and we are going to follow the same format we have been following. So we are going to have 3 presentations, a team presentation from Colombia. Montasser is going to do his presentation on aligning CRVS agenda and adolescent health. And then we are going to have a presentation from Daniel from the Swiss Technical Tropical and Public Health Institute, right? And we have the presentation from Dr. Nashaat Taani from Jordan. I understand your presentation was already presented in the previous session, but this is now to the whole plenary. So without further ado, we are going to have 8-minute presentation, and if you can shorten it, the better, so that we have more time for conversation and exchanges and learning. So let me start by inviting the Colombia team, Edna, Valle, and Carlos, to kick off, please. Want to go there?
Actually, I'm going to do it by here. Thank you. Bonjour à tous.
I'll try to make my presentation in French. So we'll show an exercise we did in Colombia with the stats on mortality or fecundity with the use to estimate the fertility in Colombia through adjustment for coverage of birth with immunization. So that's the order of the presentation. Next slide, please. Next slide. Here. So it's another colleague, Edna, who is the coordinator of the Civil Registry and Vital Statistics System. She's going to explain how it works in Colombia.
Vital Statistics of Colombia is a leading presentation. Well, the begin with this system is composed by 2 systems. The first one is Vital Statistics, is formed by Ministry of Health and Forensic Institute, who are the responsibility for the medical certificate of life, birth, and death. For more specific, the health sector and the medical forensic are the ones to make those certification, while the Statistic Institute disseminate the official information provided by another entities. And now the civil registration is the one conduct the legal registration of the birth and death in the country. The entities on this system are the civil registry and public notary. This registering can be done by medical certification or certificate witness, example, midwife, father, or family. These dual independent and complementary subsystems. Vital statistics collect information on the frequency and of the events as well as their characteristics and the person for putting a statistic proposed. And the civil registration, the continual and permanent recording of vital events occurring for administrative or legal purpose is this composed in Colombia, the system.
Thank you. OK, après cette générale présentation.
After after this presentation on vital statistics in Colombia, I'll show you an exercise we did with the vaccines registry in Colombia. We're trying to follow a coverage of the birth registry. Here, I'd like to show you the total fertility rate for Colombia since 2017. As you see in gray, there's the undercoverage of registry. We were able to identify a register with expanded coverage. It's the expanded program on immunizations. There's BCG for tuberculosis. So we found out that is a correlation with the register. Here we have a tree network. The orange line is the birth registry, the number of birth, and after the blue line is the vaccination registry. And so as you can see at the beginning, the vaccination registry has larger coverage, but this year it changed in relation to the birth registry. Now the birth registry has larger coverage than the immunization coverage. So we use the information from the vaccination registry to understand how it helped the coverage, but also to take into account that the vaccine registration can have coverage issues, but we use it all the time to understand how things are evolving. After, I want to show you an exercise we did, subnational here. They are all the Colombia department. There's 33 of them, and we made a comparison in absolute number and relative number to know which department with more coverage problem. For example, we underline Bolivar, Cordova, where there were more coverage in relative and absolute numbers. Afterwards, with Chocó, Lahuaquijac, two departments with more problems. And it explained this lack of coverage because they're more indigenous population and more mortality. So it doesn't show improvement in the register. I want to stress here that data of 2014, at the time, the exercise was done, and we did it in 2016. This is why you have 2014. Afterwards, I'll show you how we update it. Here, the most important is the National Stats Office is working to improve the birth registry in all the 33 departments. It works in 29 departments and improve registry by 78 to 80%. Afterwards, we repeated the exercise for the municipalities, 2013 and 2014. It's almost the same exercise. And we're able to identify that in those departments, however, we work in the 15 municipality. So in 6 municipalities, we highlighted the figure, and the improvement was 82% and 83%, respectively. Afterward, we use the registry information on vaccination and birth to correct the fertility rate, to do a retrospective reconstruction and for the fertility rate. The information that was useful with this type of exercise, it gives us information to talk to government and show where there's a need ours to. So it gives us information of other institutions to know how the coverage works. For example, the Ministry of Education and Health more coverage. And what else can I say? Then, what are the challenges now? Last year, we worked on a document which the analysis of population studies. We did it at a national level, and we implemented this and prepared documents for each ministry, so they be informed of the quality of those registers and why it is important to improve them. And finally, for the next steps, we want to use that information and see where are the issues in different territories, and we're going to use the 2018 data to see how the things went.
Presentation. I'm sure there will be some questions because it is quite an interesting research that we are undertaking. Montasser, over to you.
Thank you thank you very much. Thank you. I will try to stick to the 8 minutes. I will make maybe less, hopefully. My presentation today is very simple and a very simple message, or a very straightforward message. We cannot achieve the SDGs without counting adolescents. Right now, the SDGs are not set up to count adolescents, so it is likely that at the end of, by 2030, there will still be adolescents left behind because of that. So I'll give you some examples of how in the health sector and CRVS sector this could be addressed. So all of you know these numbers better than me. 166 million, the number of people whose births are not registered. 70 million, the children under 5 who lack birth certificate. Needless to say, governments are not really well positioned to make informed plans if this, without these complete numbers, without the denominators being known. There are some positive signs, investments in data, in CRVS, and importance of SDGs for accountability for governments, but there are, of course, capacity gaps and reporting gaps. And that is from the Sustainable Development Report 2019, this lack of accurate and timely data on many marginalized groups is already pointed out. We're only now less than 10 years away, and we still have huge gaps in the data, and that leaves especially vulnerable individuals invisible, and the likelihood of their continued invisibility in policies, plans, and national plans. Of the 232 SDG indicators, only 53 of them are gender-specific indicators, meaning requiring gender disaggregation. Of those 53, only 18 of them are call for disaggregation for adolescents or youth kind of age group. It's, this is not even to say that the quality of the data that is collected in many situations is suboptimal, to say the least. So this is, you can't probably read this too closely, sorry, the text is too small, but really the point here is that just giving examples of some of the indicators where the adolescents are absent. Ending hunger, there's no indicator that links that related to adolescents. Ensuring healthy lives and promote well-being for all at all ages. The only indicator is related to the adolescent birth rate. For achieving gender equality, the indicators are either missing age groups or missing sort of the different age groups of adolescents and youth. So this is, I mean, you all have access to these numbers, and thanks to UNFPA for providing the graph. It just sort of makes you wonder, how can you get accurate data for national planning if you don't know the denominator? Like how many youth are there? How many adolescents are in the country? And then, of course, what policies need to be addressing them. Then we come to the point of the intersectionality. So we talk about adolescents, age group, gender disaggregation, but there are other variables that influence why people register, or when they register, or why they're not registered. These are examples from the Middle East, North Africa region. Children from the richest households are more than twice as likely to be registered as children from the poorest households. In the Middle East, North Africa, the richest quintile is 95% more likely to be registered, likely are registered, compared to the poorest quintile, 75%. Birth registration is higher in urban than rural areas in almost every region in the Middle East, North Africa region, 78% in rural and 95% in urban areas. So again, this is sort of the perpetuation of invisibility that is related to just where someone is born. And of course, that is really should no longer be acceptable. Early marriage, and this is sort of coming into some examples of what can be done, or how can we, as CRVS community, help to address these gaps. Middle East, 1 in 5 in Middle East, North Africa were married before the age of 18. Nearly 45 million women married before the age of 18 living Middle East, North Africa. 700,000 child brides in MENA every year. Staggering numbers. One of the things that we have, through partnership with UNFPA, with colleagues in UNFPA, sort of introducing now with the demographic and health survey a question about marriage, a consistent question for marriage registration. So for the first time, we will eventually, soon hopefully, have comparable international data on marriage registration. Finally, we will be able to see how, at what, whether people have marriage registration certification or registration or not, and start to compare what knowledge gaps and policy gaps that need to be addressed. Another example from DES, and we heard yesterday speakers speaking about the differences of birth registration between men and women. And again, this is thanks to work from UNFPA and several other groups here that mentioned this work. One of the things that we are supporting and collaborating with UNFPA on is building the evidence based on the social and cultural norms that affect registration rates. There is a reason why women are less registered than men. There is a reason why women in rural areas are particularly less registered than men. We need to understand that and need to engage with community and norms, and as Irina's session today was talking about, and the group and the workshop talking about sort of the norms that are barriers for registration of deaths. This is from WHO, adolescent population size and overall rates of mortality and disability-adjusted life years, lost globally and by modified by region. Again, these are numbers we all of us rely on these numbers produced by WHO, UNFPA, UNICEF, and all the multilateral organizations. Again, you know, sort of questioning how can we build on how we can build on those numbers that don't really have an accurate or reliable denominators in many cases. So examples of data gaps that are also connected to the health system that are could be linking the registration of the health system, sexual and reproductive health for unmarried sexually active adolescents, refugee adolescent girls, and in some cases boys, their absence from registration anywhere in any system, school-based infrastructure for students with disabilities. You know, we don't have any, there's no research on that, not much research on that. Data on early adolescence, age 10 to 14, is the most understudied age group of adolescents or youth. Synthesis reports from the voluntary national reports for 2018 conclude that there is still little tangible progress in meeting their age and gender-specific needs for the Agenda 2030. I give two quick examples, realizing I have no time left. Two quick examples of partnerships and projects we are supporting from IDRC and from the Center of Excellence in Palestine and in Jordan, of trying to understand the perspective of adolescent girls themselves. You know, what is it that they need? What is it that they would like to see in terms of the messages or the gaps in their knowledge, and giving voice to them to really speak their mind. In Jordan, we're supporting a project to try to harmonize a reproductive health registry that linking or in one place having information on refugee women and women from the community in one of the directorates in Jordan, to try to, again, to sort of have one place where you can have all the needs of the women, reproductive health of women registered in one place. This is just sort of the sum up of those examples I gave in terms of action to accelerate progress, improving data systems, understanding the barriers to data completion, giving voice and understanding different contexts of adolescents, and designing inclusive systems that are interoperable, where that the youth adolescents come in contact with. For governments, without knowing how many adolescents they have, where they live, what is their status, how can there be plans to not leave them behind? They will be left behind if nothing is done by 2030. Thank you.
Thank you very much, Montasser. I think we'll come back to you, and since the government of Canada, through the Center for Excellence and IDRC, they contribute to the GFF, I would like you to link now to the RMC age in our discussion. So let's go to the last but now presentation, because no, it is you. It's for you. Okay. Yeah. Because he doesn't have a presentation.
You're not going to skip so easy.
He doesn't have a presentation, but we can. Yeah.
I'm going to stand because
Thank you, Daniel. Yeah. Okay.
So I speak better if I'm standing. So, good afternoon, everyone. So we are going to talk about death and causes of death. And what we've tried to do at the Swiss Tropical and Public Health Institute is to look at the mortality statistics with a gender lens. And we've collaborated with WHO in doing this analysis. So women and men, we are not equal. That's clear. And we are not equal when it comes to health. And you see, this is coming from the statistical report from WHO in 2019, and you see that the life expectancy in men and women is different across all age groups, and this goes across all countries. This is a fair representation. And this difference comes from biological conditions like only women can die from maternal conditions, and only men can die from prostate cancer. You need to have a prostate cancer. So there are some biological conditions that affect this difference between men and women, but there are others that are not so biological. You have the example of a stroke or lung cancer, where where you can see that men and women are exposed to different risks and different factors, like smoking or sedentary life or healthy behaviors, and this affects the conditions that they kill them, and this creates a difference. But there are also conditions that are linked to gender roles and how males should behave in different societies and how women should behave in different societies, and this also provides or increases the difference between men and women. So this is to say, like, look, we need to understand that. We need to understand why this difference exists and what are the reasons for those differences if we want to intervene and reduce mortality for men and women and overall. So what we've done is coming back to CRVS systems and mortality statistics systems. What we tried to see how CRVS can help in understanding that difference and the reasons behind that difference, but also looking at the quality of cause of death determination for men and women, and specifically also looking at intimate partner violence and how is it captured in the vital statistics globally. For this there is a brief that we've written about this, so if you want to read about the first part, the sex differential, we've heard yesterday and today about sex differentials, and we wrote a little bit on the brief about that, so you can go and read it. I advise you to go. But for this presentation, I'm going to focus on the quality of causes of death and the intimate partner violence. And this is an animated map. This is one of the analysis on the sex differentials. You see that this is the ratio of male death rate to female death rates, and you see that they are changing over time. This is the map. This is the rate, and the greener the rate, the closer the rates are between male and female, and the reddish, the higher the difference. So you see that countries are clustered, and they are moving in this difference. They are progressing in this difference. And for me, the key point of this graph is that CRVS systems can provide this information. They can help us monitor these trends, and they can help us monitor these trends at the national, regional, and global level. But let's go to the point, to the quality of the cause of death. So the thing is that women and men, so health systems are not gender neutral. So health systems are a representation of our societies, and if in our societies we have gender bias, in our health system we also have gender bias, and we need to understand which gender bias are affecting what. And some of these, the consequences of this gender bias is that, for example, some women may not be treated properly when they have ischemic heart disease, because doctors have a bias that either ischemic heart disease is a male thing, or the type of symptoms that they have, they do not relate to ischemic heart disease, and they think that it's anxiety or some other type of condition, and they miss it, and they can die. So there are bias in the system, and this can impact the way the cause of death is identified. So when it comes to the causes of death, the idea is that we want to capture what we call the underlying cause of death. We want to capture the cause of death that trigger all the chain of events that lead to death. So, for example, if we have someone that is hit by a truck and it comes to the hospital and it has an hemorrhage, and this person died from sepsis after 3 days of being in the hospital. The cause of death that we want to capture is the hit by a truck, because this is what we want to prevent. This is what we want to change with policies. This is what will help us to make decisions in what interventions we want to apply. And when you don't but doctors, I'm a physician myself, we are not trained to identify this properly. And we don't do it very well, to be honest. And we are trained to identify the immediate cause of death, what will kill my patient today and now, but not to report it in a way that is useful for the vital statistics. So we have a set of conditions that we know that they can be an underlying cause of death. So if a doctor puts sepsis, or hemorrhage. That's useless. So that for policymaking. So this is what we call unusable codes for policymaking. Okay, yes, this is the frame. So what we've done with all the data reported by more than 100 countries to WHO in the last 20 years, there are 113 million deaths in this analysis. So we've calculated the number of unusable codes for male and females, and these are the results. So you see, males are in your left side, and females are in the right side. So you see that for the whole period from 2000 to 2015, and for the last year, there are more higher proportion of unusable codes in females compared to males. So 2.7% more unusable codes on males compared to in females compared to males. And then we say, well, okay, but why is that? Why doctors are certifying worse or with worse quality deaths from females than for males? And we really don't know. This is something that we need to investigate. But when we look at the type of what we call the ICD-10 chapters, we see that most of these unusable codes are either in the cardiocirculatory system codes or in what we call the ill-defined codes, if they put fever or hemorrhage or headache, this type of codes. And we thought, like, well, maybe it's because, like, women, they die older, they have a longer life expectancy, so there are more comorbidities, it's more difficult to identify the underlying cause of death, and this is true. So there are more unusable codes in older ages. And this is true for the two big groups, the cardiocirculatory and the ill-defined. But then you see that for the ill-defined codes, even in younger ages, there is a higher proportion of unusable codes in male compared to women. So there must be other reasons. And if you look at the external causes chapter, this is higher for males compared to females. So there are more unusable codes in males for that chapter. So what I'm trying to say is, like, we don't know what's going on, but there is something going on there, and we need to investigate it. We need to understand why there's this difference in the quality of reporting of doctors because this is coming from countries with more than 70% registration completeness and with systems good enough to produce this type of statistics. So yeah. So it could be because women die older. It could be because men die from injuries that they are easier to identify. It could be because doctors, we don't understand what's going on with women because most of the medical science has been done around males. It could be because there are errors in the diagnosis. So we need to investigate it. We don't know. And yes, in my last minute, talk about the intimate partner violence. So what we did with the same database is we thought, okay, how many deaths due to intimate partner violence are in the data set? In these 113 million deaths, how many? So I'm going to skip a little bit this. So these are the results. These are for all countries. So we, in total, since 2000 till 2015, I think there are like 300 deaths overall, which doesn't make sense. And for women, in 2015, there were 22 deaths in the 100 plus countries. And we know that this can be true because my home country in Spain, we had 1,000 deaths due to intimate partner violence since 2013. So we thought, like, where are all those deaths? What is going on? Is that countries are not reporting? And again, there are different reasons, and we don't really know we don't have a clear answer now. We hope to have it in some time. But there is one problem or one issue is that there is no in the current classification of diseases in the ICD-10. I'm not sure about the ICD-11, the new iteration, but in the ICD-10, there is no way to say this was committed by their partner, by the intimate partner. If it's assault, there are just two codes where you can say it was the spouse or the partner, but if it's assault by handgun, assault by drowning, you can't say. So currently, you cannot provide reliable estimates on intimate partner violence homicides from the statistics produced by countries, from vital statistics. And that's why some countries, they are developing their own parallel systems to capture this. And But also,
Daniel?
yes, yes, last point. So, but also is how the systems are designed. Is some of these deaths, they probably end up in the police system, they end up in the judiciary system, but they are not linked to the vital statistics, or they are not provided with enough information to identify them as an intimate partner violence homicide. So again, we don't. So lots of questions, at least for us, lots of things to understand. But I think this for us was eye-opening in the sense of, because we didn't find too many studies or papers looking into these two aspects, the quality of causes of death for male and female, and the intimate partner violence overall. And yeah, I skipped the summary. Thank you.
Thank you, Daniel. I think many colleagues here will come back to you while looking at the intimate partner violence. I think this is part of the GBV and the inequality. Last but not least, Dr. Nashaat, Taani. So I have two questions. We don't have a presentation, so we start now the panel conversation with you. When Jordan was presented in the previous session that you have modernized the CRVS system in recent years. And there are many initiatives that are ongoing, aligning the systems. Can you share with us and with the colleague here some of the recent advances and lessons learned from the work in Jordan when it comes to CRVS?
Okay. Thank you, Ramos. I'm sorry because my language is not very good. Not good.
No, we can
okay. The civil registration and vital statistics system in Jordan is highly organized one, especially with reference to the regional situation and the challenges of development and displacement because of the conflicts and crises in the wider region. Registration in Jordan is computerized and centralized. There is annual statistical reporting, and all vital statistics are aggregated by gender. Birth registration is almost complete at 98%. We do have changes on death registration, especially among women, but we are working on this. I would like to highlight two initiatives. First, the Jordan Maternal Mortality Surveillance Response System, which was discussed in further detail earlier this morning. The Jordan Maternal Mortality Surveillance and Reporting System is a milestone for the Jordan Maternal Mortality Surveillance for Jordan government, and it also remarkable achievement at the regional level. Second, we are currently in the final stage of launching a new electronic linkage project between the civil registration database and the public health care facilities database. At this stage, we are starting with 2 hospitals, but this will allow to better monitor on report on birth and death registration data and expand the system soon. Briefly on the lesson learned, both the Jordan maternal mortality surveillance response and the electronic linkage initiative would not have been successful without the collaboration with national partners and stakeholders. The engagements of the local communities on the commitment at the top level of the discussion, making pyramid. Such initiative require a lot of investment. Field work, monitoring, and continuous improvement, but one of the first essential ingredient is there, which is the national commitment. The factors become more feasible and possible. Awareness also plays an important role on both the supply and the demand side, particularly on the demand side for refugees and the more vulnerable population. Responding with what has been emphasized in many intervention and speech yesterday and today. Thank you.
Thank you very much, Doctor. I think we are going to keep the next question at when we interact, because I want to reverse. The time is showing that we are just left with 15 minutes. I want to sacrifice myself with my questions, and first look at the interests of the colleagues here, and open up with questions, and then if there is no inspiration, then I will come back to my question. So, yes. Ça sera en français la question.
Oui,
my question's in French.
Voilà.
Well, good evening to everybody. I'd like to congratulate the initiative from this panel, especially that I'd like to say thank you very much for the last communication that was done by Jordan. The Burkina Faso, my country, is following the same thing, which is what is happening in Jordan. So what is going on now in Jordan with electronic registration and the collaboration of its partners? Well, on behalf of my government, I'd like to congratulate the UNFPA efforts. That there has been a modernization of registration in Burkina Faso. When it comes to gender equality, we need to have this database. If we don't have this database, it'll be difficult to fight all of these inequalities that exist. So I'd like to congratulate here the contribution of the actors here, and my country is thankful for what has happened, and we'd like to share this information with the other African countries.
A comment, not a question to the Jordan team, but I will still ask that the teams continue dialogue and then exchanging. Yes, Ariane. Please, you can stand up there if you want to.
Mine is a question.
Yes.
For Daniel mostly. Thanks for great presentation, and the data that you showed was great. I do feel that the gender differences were far smaller than I would have expected. That's not to say they're not important, but far smaller than expected. And what I would put to the group, of course, this was a panel on gender, but I would say the difference in income groups in those countries is way larger than the gender differences. So that would be that's not a question, that's a comment. For me, that would be a priority. Would you agree to that? And then I think the intersectionality is absolutely critical there, because you may well see larger gender differences when you differentiate them by income group.
Great contribution. Yes, you can answer to that.
Totally agree, and this is for us the next step, because yesterday we were talking with the Colombian team, and they did a quick analysis on their data set, and it seems that in Colombia is just the opposite. There are more unusable codes in male than female compared to females, and we need to understand what type of countries, in which type of countries occur this, and within countries, because in terms of gender bias from doctors, if you are a woman, you are kind of bad. But if you're a woman and also you are black, then you're worse. And I agree with this intersectionality of different factors on one specific individual, and we would really like to see how this influences these results. And yes, yeah.
Thank you.
Thank you for the question.
Thank you. While people are reflecting, maybe I can go back to the Colombia team here. It was interesting to see how you used the linkage between immunization and registry, civil registry. But going further to address inequality, can you go explain how we can look at inequality in a society like Colombia, where we have the trend with Afro-descendant, and then, of course, when you look at the inequality, and, of course, bringing this back to the difference between men and female.
Okay. In English, it's okay. For the first time when we did the exercise, the register of vaccine didn't have information about a lot of information about the sex, but actually they had information about the indigenous people and Afro-Colombian people, and also rural and urban areas. And for that reason, we identified that the majority of the departments that have problem was the departments that have a more ethnic population. When we crossed information with the sex, actually didn't show an important difference, and for that reason we focus more at the ethnic and location of the population. We identified that different.
Montasser, adolescents, I don't know if you have chosen to focus on adolescent health in general and let out the reproductive health, maternal, newborn. But today, when you look at the investment that Canada is making through the Global Financing Facility, adolescent fertility might be linked to early child marriage, expose adolescents to risk of dying or morbidity, and that has an impact in the overall human capital. Also, what is the take of IDRC in such impact on adolescents? Because if we are talking about making an investment case for CRVS, is unless we can start connecting to the loss of a country or community or a family, we cannot get the traction to continue developing the CRVS system in countries. What is your reflection on that?
Thank you very much, Benoit. I wasn't really, thank you. I wasn't suggesting to have a separate system to record indicators or the report for adolescents, but there are already systems that are being built, hopefully, systems that are already being built to collect information and registration, improve registration rates, and investments in registration. And what I'm advocating for or promoting is having, to the extent possible, having all these new systems, all those new collection tools be gender and age specific. And within the age specific to also be sub-age specific. So the 10 to 14, 15 to 19, and 19 to 24. These are age groups that are traditionally neglected in the collection of the information, and policies are lagging behind in part because of the lack of information for the age groups, especially the 10 to 14. So it's really complementary, but this is to highlight that even though the SDGs are our visionary goals, ambitious goals, aspirational goals, even within that, we have to really be careful that no one is left behind in the no one left behind agenda.
Thank you.
Thank you.
Yes, Lela.
Thank you very much. Hear me? Thank you for your presentation about the death and causes of death. Bit of a difficult subject, but you know, when I want to ask you if you could repeat some of the statistics around the intimate partner violence or those deaths that we know women have died as a result of intimate partner violence. I remember when we were trying to put together statistics on femicide, it was very, very difficult. I mean, we know that women are dying at the hands of intimate partners, or non-intimate partners, but certainly intimate partners. And actually, most of the cases are at the hands of a man that she typically knows or is related to. We had to patch together data from UNODC, Small Arms Survey, ECLAC, for example. We were focusing, for example, on femicide in Central America, and it was very difficult to get accurate data. And we had to patch together these different data sources to come up with some kind of estimate or percentage for our advocacy. So in hearing you talk about vital statistics, and the fact that we have such a data gap in terms of why women are the lack of data, first of all, in terms of recording their deaths, but why they're dying, and seeing that there's this differentiation between the mystery box. We know in a lot of cases why men are dying, but there's a huge question mark around why women are dying. And that the systems aren't necessarily talking. So if you have the Ministry of Justice that has crime data that UNODC, for example, is collating or working on, doesn't speak to the other administrative data. I find that incredibly frustrating. So there's so many challenges, and it's like, where do you start? But I can see that this has a lot of potential. So two parts. Could you please, restate the statistics around the IPV, and also just generally, what are your thoughts on connecting the dots, but also these enormous challenges that we have ahead of us?
Okay, thank you for the challenging question. So I think there are several things there. So yes, there is one systematic review that tried to collate several surveys looking at intimate partner violence homicides. And up to 40% overall of all homicides in women are committed by their intimate partner. And in Asian countries, this goes up to 50 or 60%. So it's a real problem. And the thing is, so for me, hopefully for all of us, statistics are there to make decisions and to in this case, to prevent those deaths. So in the one issue with the classification is that we can know how many deaths, how many women die from an assault with a handgun, by an assault with drowning. But actually what we want to know is how many were killed by their partner. Because this is what we want to prevent. Probably putting more laws against handguns and blah, 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 but it's the partner in the case of women. So there is some work to be done. And in morbidity, not in mortality, but in morbidity, there are ways to assign like a subcode to say this was committed by the partner. But in mortality, there isn't. And I think there is a gap in the classification. Hopefully, with the next iteration of the international classification, they fix that somehow. But then there is the issue about the systems and how the systems are designed. And we are doing a lot of work on. We come from we work on system science, and we try to see the CRVS system as a system, and we are doing a lot of work on medical legal death investigation systems and how in the frame of road traffic accidents, but now this comes really into play, and we see that there are so many there are silos in CRVS, but if you look at medical legal death investigation, there are even more. You have the police, you have the Ministry of Transport. There are many other silos. So, and I'm hopeful that we can link them, because we are using one methodology that is called business process management or business process mapping. And with that methodology, what we try to bring is all the stakeholders to the table to look at the processes. In someone is killed in some community until it's a +1 in the vital statistics, all the different steps that you need to that the process need to follow. And once you have everyone there sitting at the table, they start creating this collaboration. Sometimes they don't know each other. It's a matter of knowing, like the police knowing the people in the health sector and knowing the people in the civil registration sector. So I'm hopeful that we can link this system, because there are low-hanging fruits there. The police, they have very good records on all these, on violent deaths, on accidents, and we can just take the data from them and include it in the vital statistic with some quality proof. But I think it's not, technically it's completely possible. It's more about the governance and the politics of that, how to share data across ministries and how to to link different agencies. That's the tricky part. But the technology is there. It shouldn't be difficult.
Thank you, Daniel. I think we have the colleague from WHO who wants to complement your answer, and then after that, we are going to close this panel.
Okay, thanks very much. I'm just going to make a comment related to the adolescent work. I'm Kate Strong. I'm from WHO, and I do work on cause of death in children and adolescents under 20 years old. And I guess I really enjoyed these presentations, so thank you very much. I want to make a little bit of a plug for another neglected age group. Of course, when we look along that life course from birth to 20 years, we see that we've had great gains in child survival under 5. And then as we go above 5, we have this missing older child group, which is that 5 to 9-year-old group. And when we look at the 10 to 14, actually 10 to 14 as an age group has the lowest death rate of the entire life course. I call that the protected zone. And I have a young son who just turned 14 today. So he's got one more year in that zone, and then he's in the danger zone, because that 15 to 19-year-old age group, particularly for males, is really where we're seeing a rapid increase in deaths from injuries, road traffic injuries, interpersonal violence in some regions, collective violence and legal intervention in other regions, and self-harm is becoming a particular problem as well, so suicide. But the 5 to 9 group is a group that's right on the edge there. It's still dying from some of the preventable childhood illness conditions, such as pneumonia, diarrhea, and malaria, but it's entering the injury danger zone as well. So as we think about that at WHO and our work with the SDGs, that's going to be the real neglected group for that age range. Thank you.
Thank you very much for that great contribution. That we close our this panel. I think we were exploring gender dimension of health and the CRVS system. So let's continue reflecting on how we continue engendering CRVS system and not forgetting why we are doing that. It is to make sure that we address gender inequality, that we improve the well-being, that we build human capital. I think let's keep that in mind. People, human design system. Thank you very much. Please applause for the